Hi, I'm Dr. Josh Zacharias. I work for Countryside Large Animal in Greeley, Colorado. Today we're going to be talking about equine navicular disease. I'm board certified surgeon, and I am also board certified in sports medicine and rehabilitation. I also am a farrier and shoe horses fairly routinely as well in some of these horses. My caseload is primarily Western performance horse cases, and I also work on some of these other dressage and jumper horses as well. The first thing we need to talk about is the anatomy of the area of interest, which is, of course, the foot. On these images, to the left is going to be dorsal or towards the front of the foot, and towards the right is going to be the palmar aspect or the back of the foot. If we take the skin off of these images, we're going to see the collateral cartilages of the coffin bone, or P3, and of course we also have the hoof wall. When we take that hoof wall off, we expose the sensitive lamina that is covering the coffin bone, and also we can see the solar corium. These tissues are going to produce the hoof wall and the sole. The digital cushion is in the back, and it is just a fibroelastic structure that is going to dissipate concussion naturally. When we remove those structures, we can see the common digital extensor tendon, which is going to extend the coffin joint or the digit. And on the right, we can see the deep digital flexor tendon, which runs down and attaches to the bottom of the coffin bone. The bones that are of interest here are the short pastern bone, or P2, and the coffin bone, or P3, is at the bottom. At the coffin joint, there is collateral ligaments on either side of the coffin joint that stabilize the joint. There's also some vessels, vein, artery, and nerve that runs down alongside the deep flexor tendon on either side of the leg and supplies the tissues with blood as well as sensation. As we go on further here, we can see some synovial structures. These are the coffin joint, the flexor tendon sheath, and the navicular bursa. We'll get a better view of that here in a slide or two. These structures are going to hold synovial fluid, which are going to help give nutrients to the cartilage and give lubrication to the structures that are inside these pouches. Going further, as we take the deep flexor tendon off of these images, we can see the collateral suspensory ligament of the navicular bone, which attaches to the top side of the navicular bone and helps suspend that from the bottom of the top of P2. We can see the navicular bone more directly, as well as the impar ligament, which is a ligament that attaches to the bottom of the navicular bone. If we turn the foot over, we can see the sole, the frog, and the white line, and there's other structures here that I won't mention of the natural external structures of that foot. As we remove that, we expose the bottom of the coffin bone, and we can see where the deep flexor tendon runs over the top of the navicular bone and attaches to the bottom of that coffin bone. When we remove that, we can see the navicular bursa a lot more clearly. The impar ligament is also seen here, attaching to the bottom of that navicular bone, and it does attach then to the coffin bone as well. Here's a more close-up view of some renderings of the navicular bone. On the left, we can see the articular surface is the brighter white cartilage surface of the navicular bone, and that is going to be within the coffin joint. And on the right two images, that's showing the flexor surface of the navicular bone, and this is where the deep digital flexor tendon runs across the back side of that navicular bone. These smaller circular structures on the distal end, or the bottom of the navicular bone, on these images on the left, those are nutrient vessels or synovial invaginations, where vessels supply the navicular bone, and those become important as we look into the pathology of navicular disease. So what is the function of the navicular bone? Its main function is to act as a physical fulcrum, or a object that the deep flexor tendon can run over or behind, and provide a constant angle of insertion of the deep flexor tendon into the coffin bone. So it is mostly biomechanical in function. The definition of navicular disease, as explained in this text here, is it is a chronic forelimb lameness associated with pain arising from the distal sesamoid or navicular bone and the closely related structures, including the collateral ligaments of the navicular bone, the distal sesamoidian impar ligament, and the navicular bursa, as well as the deep flexor tendon, but this does not include deep flexor tendinitis. So as you can see, it is not necessarily a single disease entity, but it does include the navicular structures. It has been recognized as far back as 1752, and there's some fossils that have been found that have some suggestion that there might be navicular disease associated with some of these fossils as well, so back even further. Navicular disease is commonly seen in mature riding horses, especially the quarter horse, but also other stock breeds such as the Paint and Appaloosa. It is also seen in warm bloods and thoroughbreds, but not often seen in the hot bloods such as Arabs. It is usually seen having onset of clinical signs at 7 to 9 years of age, but this can be very variable. It can be accounted for 1/3 of all chronic forelimb lamenesses in the horse. So what's the history of a horse with navicular disease? We often see these horses having a history of the owner noticing the horse pointing a limb while at the hay trough or standing at a trailer tied. These horses will maybe point one limb or the other, and they can shift from one limb to the other. It's not necessarily just one. And of course, the main thing is the exhibition of lameness, and this is an alteration in a symmetrical normal gait. It is often bilateral in occurrence, and it's usually worse when the leg is on the inside of a circle at a trot. It is worse on hard ground, and it's also noted that some of these horses have a short, choppy gait, and they're rough to ride. There's some question whether or not this is hereditary. Probably the biggest reason for that is that the conformation of the foot plays a big role, and we know that conformation is, of course, hereditary. So poor foot conformation is one of the main factors that these horses with navicular disease will have. A lot of these horses are going to come to us with a low heel and long toe conformation, but not all of them. Some of them are more upright. The picture on the right depicts that conformation, and the x-ray or the radiograph on the lower right is going to show the angle of the coffin joint and what a low heel is going to do to that coffin bone, and we'll see that a little bit later on. The hoof pastern axis is normally should be straight or in line, so the pastern should be in line with the axis of the foot, and usually some of these horses, when they do have a low heel and long toe, are going to have what's called a broken back hoof pastern axis. Sometimes these horses are going to have contracted heels, and that's going to be potentially a function of chronic lameness. As these horses aren't bearing weight or they try to protect these heels, they are going to, those heels will contract because they're not bearing the force of their weight. The small feet relative to body size is commonly seen in some of these horses. Not every breed line or family line is going to have a good foot conformation or be selected based off of foot size, and this can of course play a role. The smaller the foot, the more weight per square inch of the foot that it needs to take up. And then of course sometimes we can have these horses where they are poorly shod or poorly trimmed. They can have some imbalances, whether it's from the toe to the heel or sometimes medial to lateral, so from the inside of the foot to the outside. That can cause some abnormal stresses on the navicular structures. Going on forward, we need to diagnose this, where the lameness is coming from or where the pain is coming from. And so as an exam, as your veterinarian is going to look at your horse, the first thing we're going to do in a lameness evaluation is going to do a physical exam. Look the horse over, palpate different structures. Here, this picture, I'm palpating the tendons of this horse, and of course we'll go down and palpate about every structure that we can get our hands on to see if there's any abnormalities in swelling or heat or pain. And then we go on further and examine the gait of the horse. We'll usually watch this horse walk and trot, and often we'll watch him at on a lunge line at a lope even. But the trot is the most common gait that we evaluate lameness on because it is a symmetrical gait, and it's most evident at that gait. We go through and do flexion tests where we hold joints in flexion for a period of time and watch them go to see if there is an increase in lameness or change in the severity of lameness after holding a leg or a joint inflection after a period of time. Navicular horses often are not going to have any positive response to flexion test, especially of the lower limb. Sometimes they do, especially if they have some coffin joint arthritis. They do, however, often respond to toe elevation, where we put a block under the toe and raise that toe to put strain on the navicular structures. Most of these horses are going to hoof test positive, at least over the frogs, but not always. And then most of these horses are going to have a partial or full response to a palmar digital nerve block, where we put some anesthetic over some nerves and block a certain region or the heels of a horse's foot, and then watch them go after that has set in. And if they go to being sound or improved or a change in gait, that's significant that that's the source of pain is in that area. And in some cases, we will shoe them differently or do some different treatments, and if they respond, sometimes that helps in our diagnosis. So this video is a video of a horse trotting to the right and to the left, and in both videos you can see a few strides of the inside forelimb showing a bit of lameness. This horse isn't dramatically lame, but there is some lameness associated with the right front on the video on the left and associated with the left front on the video on the right. These photographs depict some of these diagnostic methods we were talking about. The photo on the left is a picture of a palmar digital nerve block. We put anesthetic at this location, about 1.5 to 2 cc's of mepivacaine, or in some cases lidocaine, over the inside and the outside. There are 2 nerves that we block, so there's be 2 injections, and then we let that set in for about 7 to 10 minutes and see if they are going to take them back out and trot them, and if they improve, then we have a positive response, and we grade that on usually percentage of improvement. The photograph on the upper right is a picture of a hoof tester, where we can put focal pressure over certain areas, in this case over the frog, and see how the horse reacts. A lot of times they're going to try to pull their foot away, or at least show some resistance to having the pressure put on. And then the photograph on the lower right is a toe wedge, where we try to put more strain or more pressure on the navicular area, the navicular structures in the heel of the horse. So once we've detected where the pain or where the lameness is coming from, we go on to imaging. And quite often, and the mainstay to our imaging is and still remains to be radiographs or x-rays. The upper left image is a photograph of a lateral x-ray of a foot. And then the x-rays are going to show mostly bony structures. Sometimes we can see some other things like gas pockets for abscesses or some other mineralization of some ligaments. The photograph on the right is an ultrasound image coming through the bottom of the foot. And of course now we have the advances in imaging with the horse, which is mostly MRI. Most recently MRI, and the photograph on the right is a transverse section of an MRI image. The photograph on the left is a nuclear scintigraphy image, and that is an image where radioactive substance is injected in the vein of the horse and goes to areas of bone remodeling and usually inflamed bone. And so this image is a image of the navicular bone having an increased radioactive substance uptake. We can also do bursoscopy, where we put a camera into the navicular bursa, an arthroscope into the navicular bursa that's attached to a camera, I should say. And then we can also do bursography, which is an x-ray where we inject contrast dye into the navicular bursa. And CT is similar to MRI in the fact that we can do image slices, but it is similar to an x-ray in the fact that it looks at mostly bony tissue. So when we're taking x-rays, 2 of the main views that the veterinarians are going to take are these 2 views, which is a 60-degree where we shoot the x-ray beam through the foot in this direction, and the gray bar on the bottom is depicting the plate that the horse would be standing on that is going to detect the x-rays, and that's going to get our image in this lower right. The other way is what's called a navicular skyline or view, and this is where we're shooting X-ray beam down through the from the back of the horse's foot to the bottom of the foot, and we're going to get the skyline image in the lower left-hand image. Here's just a little slide showing what an MRI does and how those images are taken. An MRI takes slices of the horse's foot and takes one of those slices and produces an image. And so we can go sequentially through these slices and look at the anatomical structures of this horse's foot. And it is used, it's magnetic resonance imaging, and so pulse magnetic field is produced, and a coil is then used to detect the different structures or the different tissue within that foot. And it is very sensitive in soft tissue injury. So going on forward, what are some of the differential diagnoses or other things that can present as navicular disease? And of course, that includes most of these structures that are involved with around the navicular bone, the first one being the impar ligament. And then also the collateral suspensory ligaments of the navicular bone as well can have some injury. The navicular bursa can have some inflammation or injury. The coffin joint or distal interphalangeal joint can have arthritis or inflammation associated with it. The deep digital flexor tendon or the sheath that surrounds it can have some injury, of course. The coffin bone can either have a fracture or sometimes, and more commonly, pedal osteitis, which is just inflammation of the coffin bone itself. The navicular bone can be fractured. That can be either from a traumatic insult or quite often from a severe navicular disease that has had a weakening of the bone, and that can cause a pathologic fracture. And then the heels could just be bruised as well, and that is very commonly the case. This image, or this radiograph, shows a mineralization within the deep digital flexor tendon. This shows evidence of a chronic injury or a prior injury and may not be active. And in this case, it was not necessarily the active cause of pain. However, these images are going to show some ultrasound images on the left of the deep digital flexor tendon, and the lower right hand or the lower left hand image is going to depict some of those structures. The deep digital flexor tendon in green is, and then the coffin bone, the bottom of the coffin bone, the impar ligament, and the navicular bone all can be seen on this view, as well as the digital cushion. The upper right is an MRI image, a little bit further up the pastern, but still down associated with a positive palmar digital nerve block. The white arrow is pointing to the deep digital flexor tendon and specifically an injury associated with that. The ultrasound image on the lower right is showing a deep digital flexor tendon injury of the right front foot. The left front is shown on the left, and you can see the injury is outlined in purple there, and it's depicted as being dark. So what causes navicular disease? And there's different theories associated with the pathology of navicular disease. These theories are mostly speculative. This disease cannot be reproduced experimentally. One of the first thoughts was that it was vascular or ischemic, which is just basically loss of blood flow or decreased blood flow to the bone. However, in some of these navicular diseases, we cannot identify any ischemic bone on these associated with these horses that have had this disease. There is also a biomechanical theory, and this is associated with forces that act on the structures of this area. The compressive forces on the navicular bone and the stress on the bone, as well as increased deep digital flexor tendon forces. And then chronic inflammation or degeneration of cartilage is also evident in some of these horses, and these are similar to changes that we're going to see in a joint that has osteoarthritis. So here's a slide depicting some of these biomechanical forces on the structures here. The lower arrow here is depicting the ground reaction force, or the force that the ground puts against the bottom of the foot as the weight of the horse comes down through the skeletal column. This deep digital flexor tendon has a tensile force, both in weight bearing and as well as during breakover, or when the heels of the horse leaves the ground during a stride. And also these ligaments, the collateral ligament and the impar ligament, are going to have tension associated with the navicular bone as well. These all lead to mostly compressive forces on the navicular bone. There's also some friction along the deep digital flexor tendon, along the flexor surface of that navicular bone as well, that can erode that cartilage and cause some degeneration. Some of the pathologic findings we'll find on X-ray are enlarged synovial invagination. So these are those areas along the distal border of the navicular bone where the nutrient vessels enter the navicular bone. These areas are going to have some osteoclastic activation along these vessels, and they may also become cystic. So here on these views I outlined some of the more major findings, definitely not the only findings on these X-rays. The upper right-hand corner is more of a milder case where we have an enlarged channel, we have a little bit of sclerosis. We'll get to some better images of those. And then as we go down the right side there, these images are going to have a increase in size of some of these channels where there's been some loss of mineral that these osteoclastic cells have removed in response to the unnatural stresses on the bone. The lower right hand, we have one section where some of these vessels, or some of these channels have coalesced, and then as we come across the bottom, the lower left-hand corner has a large cystic structure within the navicular bone, and also we have an area where the whole distal border is very eroded and irregular. The other type of pathology that we see is medullary sclerosis, including edema, fibrosis, and sometimes osteonecrosis. MRI has shown us that we can see fluid within the navicular bone, and the upper right-hand corner is depicting some of that, which is shown up by a brighter white signal intensity within the navicular bone. The lower right-hand corner is going to depict what we see as the medullary sclerosis. So the medullary cavity of the navicular bone is the center of the navicular bone, and it has a shell of cortical bone around the outside. We should see a distinct line along between these two areas, and in this case we cannot see that. It's faded out almost completely. On the lower left-hand corner we have an area of osteonecrosis, or a cystic lesion within the navicular bone that can be seen on the lateral view. And also I'd like to point out in this view that we have some evidence of some coffin joint arthritis, which is sometimes evident on some of these horses with navicular, and that's just depicting arthritis within the coffin joint that may be associated with imbalance of the foot or abnormal stresses on that foot. The flexor surface of the navicular bone can have some cartilage degeneration. We cannot see the cartilage on these views, but we can see the subchondral bone, or the bone that lies right underneath the cartilage. And when we start seeing some irregularities in these surfaces, we assume that there is some cartilage degeneration or even complete loss of the cartilage in areas. These changes in the cartilage are going to be similar to arthritic changes, and these lines depict some of these irregular surfaces on that flexor surface of the bone. I'd like to point out where the deep digital flexor tendon is in this lower right-hand corner radiograph of the deep flexor tendon, as it runs right over that rough surface, and that of course can cause some significant erosion of the deep flexor tendon and injury to it as well. Going on further, the navicular collateral ligament can get some mineralization or develop mineralization along their insertion on the top border of the navicular bone, and these are called enthesiophytes. And these just show up as spurs or batwing appearances of the edges of the navicular bone. The navicular bursa can also become inflamed, and it quite often is inflamed with navicular disease. It's just the synovial structure that is between the navicular bone and the deep flexor tendon, and this can be seen on this MRI image. The impar ligament can be injured as well, and sometimes we'll see mineralization or even fragmentation of the distal border of the navicular bone. So where does pain come from with navicular disease? One one of the main sources of pain is the bone itself. There's thought to be an increased intraosseous pressure or increased hydrostatic pressure within the navicular bone with the disease. There's also osteoclastic resorption of bone, which is known to be a very painful metabolic process, is the resorption of bone. And also adhesion. So when we have some scar tissue that develops between the flexor tendon and the flexor surface of the navicular bone, we can get a fibrous tissue which is called an adhesion. And this is depicted in the lower right-hand corner. As I take that photograph away, you can see between the deep flexor tendon and the navicular bone there is some areas where there is scar tissue. And of course, other soft tissue injuries, especially acute injuries of some of these ligamentous and tendon structures, can have some acute inflammation that is going to cause some pain to the horse. Here I have a couple cases of a more common finding that we'll see in our clinic. This is a 12-year-old quarter horse mare used for barrel racing. This horse has a negative palmar angle in which the coffin bone is lower in the heel region versus the toe region. And that, of course, puts more strain on the deep flexor tendon. We also have some of these collateral ligament of the navicular bone enthesiophytes. And then we have some erosions and enlarged synovial channels, mild but still present and abnormal. This is a 14-year-old quarter horse mare used for Western pleasure. This horse has been wedged up with some wedge pads, and we'll get into shoeing here in a few slides. But we also have some enthesiophyte formation and maybe some medullary sclerosis in this view as well. So what do we do about navicular disease? Of course, the first thing we can do for treatment is controlled exercise. These horses typically do not do well with just strict stall rest. They get very stiff and usually worse without exercise. So we like to exercise them in a controlled manner. Excessive exercise, however, may have negative effects. If we ride these horses all day long, sometimes these horses cannot hold up to that. So the level will vary with each individual. Each horse is going to be different in how much it can handle, and each horse, of course, has some differences in pathology that's going to dictate how much exercise he or she may handle. One of the mainstays to treatment of navicular disease is shoeing or therapeutic shoeing. It may be the most important thing that we can do for the horses is shoe them properly. What we do with therapeutic shoeing is mostly to change the biomechanics of the foot, but also to reduce stress on the navicular structures and reduce concussion that finds its way to the navicular bone. Having said this, there is no right way to shoe a horse, so we have to see what the horse likes. Some of this is through trial and error. What works on one horse may not work on another one that has similar findings or similar pathologies. Here we see some of the main components to therapeutic shoeing of a navicular horse. It's definitely not all of the things that have been tried or that have had success. However, these are some of the main things that we try to do. And again, it's not necessarily for every horse. The first thing we like to do is reduce breakover. And breakover is the point of the toe, the last point of the foot that leaves the ground as a horse is lifting its foot off the ground. So usually that's at the toe. What this does is we reduce compressive force on the navicular bone from the deep digital flexor tendon. As a horse's foot is leaving the ground, there is tension on that deep flexor tendon, and that squeezes the navicular bone against the back of the coffin joint. It also reduces strain on the other soft tissue structures, such as the impar and the collateral ligaments of the navicular bone. Some of these horses will do well in a 2 or 3 degree wedge-heeled shoe, but not all of them. Some horses like to be in just a flat shoe. So this is something that you and your farrier can decide what is best for your horse. By wedging the heel, we also reduce the compressive forces of the navicular bone by taking the tension off the deep digital flexor tendon. However, in some cases, by lifting their heel up, that heel is going to hit the ground harder and come into contact with the ground slightly before it would normally with a flat shoe. We like to give some of these horses caudal support and by doing that, that just means bringing the heels or extending the heels further towards the back of the foot. And what this does is recenters the ground reaction force, or the center of gravity, essentially under the foot. And this can increase the effective weight-bearing surface of the foot. And some of these horses do well with pads. We don't pad all of them, but some of them do like to have a pad, and what this does is it reduces the concussive force from the ground that vibrates up through the tissues and into the navicular bone. And I guess we cannot forget barefoot, keeping a horse barefoot. Some horses, especially the mild ones, that have been in a shoe for, let's say, an extended show career, some of these horses will do well by taking them out of a shoe for a period of time. And so that's something that you and your veterinarian and your farrier can decide if that will work for your horse. So this is a slide of some shoes that can be utilized to reduce breakover. Most farriers can take pretty much any shoe and apply it in a manner that is going to reduce breakover. One of the simplest methods is to set the shoe further behind the toe, or at least don't fit it to the perimeter of the toe. And in this slide, in this photograph in the middle, you can see where there's a little bit of toe hanging out past the front of the shoe, and that is going to effectively reduce breakover. This shoe also has a reduced breakover by having a rolled toe, and also the branches are rolled. And what this means is that the outer portion, or the perimeter of the shoe, is lower than the right. And you can see with just a little finger pressure here on the lower left-hand photograph, we can get this shoe to get into a breakover phase, which is where it pivots at the toe there. And so that is going to be a lot less stress, or take a lot less force on the deep digital flexor tendon as a horse goes from flat-footed to a position such as this. Aluminum also reduces concussion. I'll point that out in the fact that it does not dissipate some of the concussive forces as much as steel shoes. And so some aluminum shoes can benefit some horses with navicular disease. And it also wears more dramatically than, or more aggressively than, a steel shoe. And so the point of breakover, or the way a horse can wear an aluminum shoe, they can wear that shoe to a point where where the foot naturally breaks over. A steel shoe may not do that as easily. This shoe on the right is a horseshoe that has some breakover built into it, or a rolled toe, a lower outer rim to it, so to speak. And some of these horses, we can apply those potentially to have some caudal support and set behind the toe of the shoe, or toe of the foot. So when we go on to wedging a heel, these series of x-rays are going to show the effect of what wedging a heel, or raising the heel of the foot, is. And this is usually done with a pad or a shoe that specifically has a wedge heel into it. And again, this is usually about 2 or 3 degrees of wedge. Some horses are going to do better with more, or potentially less wedge. The angle of the deep digital flexor tendon as it goes across the flexor surface of the navicular bone is depicted with the red line. The left-handed image shows a horse that has a negative palmar angle, or where the heels of the coffin bone are lower than the toe, and it has a more acute angle to that deep flexor tendon as it crosses that bone. And when we wedge a horse's foot up, or heels up, we get less of that angle. That angle is straightened out, which in turn means that there's less tension on it and less compressive forces, as well as friction on the navicular bone. Going on to caudal support, and this has been done differently throughout the years and by different farriers. There is still a wide use of a bar shoe or an egg bar shoe that's going to give some extended support beneath the heels of the horse. However, there are open-heeled shoes that do just as well as far as giving the horse some caudal support. And what the caudal support means is that we put set the shoe out behind the heels a little bit further than natural shoeing would be. In this x-ray on the right, we have a horse that has, again, negative palmar angle, and the center of gravity, or the center of essentially where that shoe hits the ground, is essentially about right there. So it's a little bit forward of the extensor process of the coffin bone. If we put an extended a shoe with some caudal support on it, that center of gravity or center of ground reaction force probably is more accurate. It comes up through the center of that shoe and then is centered directly underneath that coffin joint. And this is going to help during breakover phase as well as during weight bearing and take some of the stress off of that navicular area. The lower left-hand shoe is a steel bar shoe that is handmade, and these shoes are quite often used as well. I used to put these on quite often, and I don't use them as much because I do tend to use less bar shoes. However, there are certain cases where bar shoes are still potentially necessary or beneficial. Some of these horses that are sensitive to concussion from the ground do well with pads. And there are various types of pads, whether they're a hard plastic pad or even a leather pad. And there's material that can go underneath the pads, such as non-supportive material or pour-in supportive material, or some of these on the lower right-hand corner is a dental impression material that is a two-part composite that is kneaded together and then quite often put under a pad. In the upper right-hand corner is a pour-in impression material, and these usually have a consistency of the bottom of a tennis shoe, do have some give, but it also protects against hard if the horse was to step on a rock or uneven surfaces, as well as dissipate just the natural concussion that's going to come up through the bottom of that foot. And it also supports the soft tissue structures. These supportive pads are going to not necessarily splint, but be more like an orthotic. It's going to help reduce some of the strain on the soft tissue structures as well. So it's not just about reduction of concussive forces. So going on to treatment, the traditional standard treatment for arthritis and navicular disease has for years been anti-inflammatory medications or non-steroidal anti-inflammatory drugs. And so these are going to be similar to what most people are going to take for a headache or something. It's just anti-inflammatory, which in turn is going to reduce pain. Phenylbutazone is the most common one that is probably used. Flunixin and furocoxib are both products that are effective in reducing pain to various degrees. Furocoxib maybe is more of a traditional or a standard longer term product that might be used, but maybe not as effective at reducing the acute pain like Bute is. And flunixin is thought to maybe reduce soft tissue pain a little bit better. Drugs such as pentoxifylline and isoxaprine have been used with various degrees of success to change or modify the blood flow within the navicular bone. And these do this in various ways, but one of the main ways is by changing the deformability of the red blood cell as it travels through some of these vessels within the navicular bone. Some horses do well on these, and other horses it doesn't seem like we get as much effect as we would like. So your veterinarian may or may not suggest something like that if you have a horse with navicular disease. One of the more common things that we'll do with some of these more severe navicular disease horses that are still in performance or still competing is either an intra-articular, intrabursal, or intrathecal. And so that's either within the coffin joint, the navicular bursa, or the tendon sheath. And this depends a lot on the pathology that's within the horse. You can't just pick one. We have to focus it to the pathology or the lesions that the horse has. Quite often we are injecting some form of steroids. Usually a triamcinolone is a very common steroid or medication that is going to be injected. And then often we'll put in a hyaluronate or HA is injected. And this helps improve quality of the cartilage and synovial fluid, as well as improve lubrication within the synovial structures. By injecting the coffin joint in the navicular disease horse, half of that navicular bone does sit within the navicular or within the coffin joint, and so we will actually get some diffusion of the steroid into the navicular bursa after a coffin joint injection. So they don't necessarily have to have coffin joint disease to get some benefit out of a coffin joint injection if they have navicular disease. And so your veterinarian will help you decide what's best in that method. This radiograph on the right is a radiograph of a needle within the navicular bursa. So it's a long needle that extends through the deep flexor tendon and into the navicular bursa. And so there's some thought that maybe we want to limit how many times we go through that deep flexor tendon, potentially causing some scar tissue there. But some of these horses with adhesions do well with a bursal injection. Going on to some of these other products that are not steroids I do want to mention IRAP, or interleukin-1 receptor antagonist protein, and platelet-rich plasma. And these have been discussed in some of the videos of talking about osteoarthritis, where these products are used a little bit more, and tendon lesions as well. The IRAP, or interleukin-1 receptor antagonist protein, is a protein that blocks some of the receptors within the synovial lining, synovial joint capsules, and these essentially shut off these receptors that, if activated, can promote inflammation. And so some of these chronic, especially arthritic horses, will do well with those. And PRP is a product that, and both of these are made out of the horse's own blood. It's processed from the horse's blood. PRP is used often for flexor tendon lesions, or even suspensory ligaments and other soft tissue lesions. And some veterinarians have had some success with injection within the joint or a bursa as well. So they may or may not be something that your veterinarian may employ or suggest. PRP is a source of growth factors that stimulate healing, as well as potentially some anti-inflammatory actions, and so we do get some good effect out of those. Going on, I just want to mention some of these joint supplements. Disease-modifying osteoarthritic drugs is what we call them, and these are polysulfated glycosaminoglycans, or PS-GAGs. There are various products out there, both injectable as well as oral, as well as HA products, hyaluronate, and again, oral or injectable. In general, there is, I usually tell clients that there's probably a benefit, definitely a benefit at the cellular level, regardless of if we see a clinical effect. However, used alone, they may not be, they may or may not have some effect or change in lameness, at least for navicular disease. So I just want to mention those. There are a lot of horses on with navicular disease that are on some of those supplements. Going on, extracorporeal shockwave therapy has been used over the last 10 to 15 years or so for treatment of navicular disease. The proposed mechanism is either through increasing or inducing new blood vessels to form within the navicular bone and some of these ligaments, and potentially decreasing some of the avascular necrosis within the bone. Also can reduce pain, maybe, or potentially through decreasing the intraosseous pressure, or decreasing the hydrostatic pressure within the bone, as well as bone remodeling. It stimulates bone remodeling, which can heal or improve the degenerative changes that have taken place. There's also a temporary analgesic effect associated with shockwave therapy, and so there's been quite a bit of success with this for some veterinarians. Going forward, some of the new products and the new exciting drugs that have come to market just in this past year are bisphosphonates. So to describe these, we need to describe some of the bone metabolism to a degree. And during times of chronic bone disease or stress, such as navicular disease, the bone remodeling is accelerated, and bone responds to stress or the forces applied to it to try to counteract those. So the compressive forces of the ground reaction force and the weight of the horse, and maybe the deep flexor tendon pushing up on it, the bone is going to become more dense, and to do that, it has to go through a period of bone resorption, and then, of course, new bone formation. And so in disease state, the bone resorption is more effective or more productive. We get more resorption than bone formation, and so that's where some of these cystic structures are thought to come from. Bisphosphonates are a drug that has been used for some time in other countries, and they've just become approved in the U.S. to regulate bone metabolism through inhibition of this bone resorption, and to balance the osteoclast, which is the cell that causes bone resorption, and osteoblasts, which are the cells that form new bone activity, and reduce the activity of these osteoclasts. And so this diagram on the lower half of the slide is depicting this. These osteoclasts are the cells, they're large cells that take the mineral out of the bone, essentially. So they gobble up the bone and form these bone lytic areas or these resorption channels. The osteoblasts are smaller cells that are going to produce and fill in these voids with new bone formation. And so this is essentially a simplified version of what bone metabolism is: osteoclast and osteoblast fighting back and forth, taking away and building up. So what bisphosphonates do, and clodronate and telludronate are two drugs that have been approved in the U.S. that block the osteoclast directly. They work very similarly, and they block or essentially kill these osteoclasts. Now, it doesn't mean that the osteoclasts go away completely. They're constantly being formed, but they do cause the osteoclasts that are active to go through apoptosis or cell death. And so this gives the osteoblast, theoretically, a chance to catch up. Remember that resorption of bone is also one of the painful processes, and this is found in, in human medicine for things such as bone cancer, that they use bisphosphonates for palliative care, and so to specifically reduce pain. And so this is something that with navicular disease we have an exciting new hope and results for some of these navicular disease cases. Other things that are done that I should mention, because they are treatments, but they're not commonly used. Some of these aren't commonly used as a standard treatment protocol. And one of these, and especially for salvage procedures, is a long-term blocking of the palmar digital nerves. So this blocks the pain transmission from the area of the navicular bone. Now this is just patching tires, so to speak. This can be done with drugs, but is usually not recommended, or it can be done with a surgical neurectomy. And I usually consider this a salvage procedure. It is definitely not a risk-free procedure. One of the main risks is that they can rupture their deep flexor tendon. Pain is a protective mechanism, and by taking that pain away, they apply more stress than maybe what those structures can handle. Other surgical treatments that are in the literature and have had some success for various veterinarians is either a desmotomy or cutting of the collateral suspensory ligament of the navicular bone, and also navicular bone decompression or drilling of the navicular bone. And I won't get into those. That is not performed mainstream, but it does have some exciting results for some severe cases. Going on to prognosis, the clinical resolution of navicular disease horses is thought to be up to 50%, as referenced here. However, in some cases, I think that maybe that's a little bit higher. Different veterinarians probably have different opinions on how well these horses are going to do. And so a lot of that has to do with what success is measured by. Is it successful because it can get back to a little backyard riding, or is this horse having to go and compete at upper level dressage or cutting or something like that? Some of the factors that are included in prognosis is the severity and chronicity, or how long the disease has been going on, of course, and then also specific pathologies, what structures are involved. The deep digital flexor tendon involvement, for example, does give us a poor prognosis, and then which treatments are employed as well. Some treatments are more successful than others. Severe radiographic abnormalities of the navicular bone are an indicator of a poor prognosis. However, some of these horses may not have that severe of lameness if they have severe navicular bone changes. I've seen some horses with really bad navicular bones. One of the radiographs I saw, or I showed you previously, was only a grade 2 out of 5 on the AEP lameness scale. And so that doesn't always match up to the clinical signs, and I've seen vice versa. Of course, some horses have completely pristine navicular bones and have some severe lameness associated with that area. and these are horses that probably have some primary soft tissue lesions, which is thought to be about a guarded prognosis. So what are we going to do with these navicular horses, or what can you expect if you have a horse that's been diagnosed with navicular disease? We've talked about the treatment of the horse, we've talked about how we go through and diagnose the horse, and some of the methods to shoe the horses as well. But what can you do when you get the horse home after the horse has been treated, and what can you expect? The first thing that most people want to know is, what can I do to ride this horse? What should I expect? And the shoeing, after a horse is shod correctively or therapeutically, some of these horses may take a few days or even a week or so to accommodate. Some of these horses may get a little bit more sore. Of course, we need to watch these horses for things like the simple, hot nail or something that you're typically going to watch for after your farrier's been there to make sure that everything goes well. But in general, these horses may take a few days to accommodate. And they can also be slow to see clinical improvement. I always tell clients that the most important thing to do with a navicular horse is get the horse shod properly, but don't expect overnight results. Very rarely do we see a quick improvement. It may take 1, 2, or even 3 shoeing cycles before we get the shoeing method and dialed into what the horse likes. And so that's something to take into account. Intrasynovial injections. So if you've had a coffin joint or a navicular bursa injected or a tendon sheath, if these horses are sound enough to be working but just not performing to their best level, these horses are going to probably take 2 or 3 days off from the injection itself. However, if these horses are being injected and they're so-called crippled or very lame, we might have to go through a period of rest or rehabilitation before, so there may be some modification there. But in general, for a joint injection, I usually tell owners 2 to 3 days off, and that's just because of the response of the joint to the act of putting a needle into the synovial structure. With steroid injections, usually we'll see a peak effect, or the best effect that we're going to get out of that injection is usually about a week to 10 days or so. For most other treatments that we've discussed, other than some of these surgical treatments, obviously, there's not going to be any change in exercise potentially. And again, it is a bit of a case-by-case basis, but in most of these treatments, like the bisphosphonates, we don't usually change what they're doing per se. If the horse does have an acute or soft tissue injury, an acute soft tissue injury that has just happened that has some active inflammation, of course these horses need to be rested and or at least have reduced activity depending on the severity of the disease, whether that's a period of stall rest and ice and viewed, or whatever your veterinarian decides is best for your horse. Going on to exercise level, it depends again on the degree of lameness. If they're a 3 out of 5 lame, they're not going to be able to go on into the cutting pen or into the reining horse show ring or anything like that. So we're going to need to get these horses to a better level of lameness, or get them sound, preferably, before they can go on to do that. So in general, navicular disease horses, I usually say, are mild to moderate in their level of lameness. However, some of these ones that are a little bit more severe in their lameness degree may benefit from a customized rehabilitation or exercise program. And this is where you work the horse into some series of different exercise levels and maybe some different specific exercises. And we need to listen to the patient, listen to the horse, see how the horse is doing. And this is usually through reevaluation, so we'll recheck these horses, see how their lameness is progressing, or that if they're becoming sound, then we can get them back into work quicker. Footing is one thing that a lot of people will ask for, and one of the things that we need to remember is that if they're having to work on hard footing, that translates into an increased concussive force. So the harder the footing, whether it's frozen ground or concrete, then we need to try to remember that these horses don't like that. It's definitely more painful for them as they're trying to get to a managed state of this disease. If the footing is too shallow, we need to remember that some of these therapeutic shoes can be a little slick. They have less traction. They're usually a wider shoe. Maybe doesn't have as much grip on them as the shoes that they had on previously. On the flip side of that is that if we have too deep a footing, we can increase the strain on soft tissue structures. The deep footing is going to put a little bit more tension and pull, and maybe be a little bit more grabby, as some people might say. And so we need to remember that just good footing in general is just a moderate depth, something that's maybe not too hard for these guys. But granted, footing doesn't necessarily isn't something that you guys can dictate when you're going to a horse show or something. Necessarily, you just got to accommodate to what's given you. But at home, especially, you can maybe adjust some of that. So in conclusion, I'd like to say navicular disease often can be managed. Of course, there's no cure for navicular disease. It is a progressive degenerative disease. However, it can be managed successfully in a lot of cases. Not all of them. As we said, the prognosis, listed in some references, is about 50%. And again, that's clinical resolution, so back to soundness. However, I think some of these new medications out, some of these more specific diagnostic methods, MRI has been out for quite a while now, and it has really enlightened us onto some of these other structures that are being injured along with just the navicular bone itself. And so navicular disease involves the navicular bone, and some of these soft tissue structures are often injured or inflamed to some degree. So the MRI has really helped us along with those reasons. So what that means is that we can offer a more specific treatment, and probably ultimately is give a better or a more realistic prognosis. As we get more of these cases, case after case, there's more case reports of some of these soft tissue injuries that gives us a better idea of what to tell you, the owner, of what your horse is going to, what to expect out of your horse in the future. And probably the biggest thing that can dictate success is the veterinarian and the farrier and you, the owner, and your horse working together. That relationship is very important. Everybody needs to have an open mind, and sometimes that can be difficult. So, try to have an open mind. The veterinarian doesn't necessarily have to be the one with all the answers, and so the farrier and the veterinarian and you, the owner, can all have input on how to manage your horse. So, those are things to keep in mind. I'm Dr. Josh Zacharias. Thank you for joining us on this talk of navicular disease. I hope this information has been helpful.